Good evening, everyone. Am I audible? Elfley?
Yeah,
Dr.
you're
Elfley?
audible. Start. Yes, we can start. You're audible.
So, once again, a very warm good evening to all the delegates and our faculty for today's webinar series. So today is the last day of our webinar, Imbha, a journey to wholesome life through homeopathy. So I welcome you all to this session. I welcome Sir Dr. Simpson Joseph. So without further ado, I would like to call Sir to please take over. Thank you.
Hi, good evening. Am I audible?
Good evening, sir.
Yes.
Yes, sir.
You can see my screen, no?
Yes, sir.
Yes.
Okay. So, I think this is your final day for this session. Your Imbha program, like whole life, wholesome life, actually. Yeah. So, you are able to understand the concepts which you discussed yesterday, like how all, like, because we have gone through it in detail about the other things related to hypertension rather than just to focus not only on hypertension. We have seen the literature says about hypertension, like what are the other components or comorbidities we have to think while treating a hypertension patient. Hope you all gone through that and you have a thorough understanding, because our aim of treatment is to reduce the morbidity and mortality. We cannot expect cure in almost all the cases. That's only in theory. In practice, it's not an easy task to do that. Maybe 1 or 2 cases we can achieve, or maybe in a small percentage, but the main aim of the treatment is always to reduce the morbidity and mortality. That is why we have, uh, as far as homeopathy is concerned, we have the liberty to go into what you call, like the prescription can be of varied thing. There is not a fixed protocol, like we have to go for with start with any kind of gastrics or antihypertensive like ACE inhibitors or calcium blockers. There is a freedom for the doctors, so the responsibility also will be more. So we will start with today's session, day 2, hypertension. Like we know, this is like a triad of diabetes, hypertension, and dyslipidemia. Today, I just want to make you to understand what is white coat hypertension. So it's a reality actually. It's a kind of syndrome whereby a patient's feeling of anxiety in a medical environment results in an abnormally high reading when their blood pressure is measured. This is called white coat hypertension. This is we can see in arthritic patient, gelsemium patient, and arsenic patients and all. So it's a reality there actually. So there is another entity called masked hypertension or MH. But in masked hypertension, so in white coat hypertension, what happens is when a patient comes to the physician or to your office, when you check the BP, he will have high blood pressure. But the opposite is seen in masked hypertension. The phenomenon of masked hypertension or MH is defined as a clinical condition in which a patient's clinical blood pressure is lower than 140/90, but ambulatory or home BP readings are in the hypertensive range. Ambulatory means 24 hours, like the patients are in a hospital, they will go for a ABPM measurement. In that condition or in home BP readings also, the blood pressure will be high, but when a patient comes to the physician, the BP will be normal. So that is called masked hypertension. The other one is just opposite, white coat hypertension, when a patient comes to your physician. Is it clear for you? So we discussed in detail about other factors which contribute to blood pressure. Now we move to, most of the patients come to you. It's not like that ailment will not be hypertension alone. It will be a cascade of diseases. It's a combination of different diseases, and they were taking many medicines for that also. So we have to know like what all medicines from the conventional treatment that cause elevation of blood pressure. Anti-infectives. Then ketoconazole is an antifungal, is well known for it's notorious for causing hypertension. Then anti-inflammatory like COX-2 inhibitors, NSAIDs, etc. cause and can cause hypertension. Then chemotherapeutic like chemotherapy patients also may develop hypertension. That is due to the medicine is mainly like VEGF inhibitors or vascular endothelial growth factor inhibitors. They are also notorious for causing hypertension. Then some herbs like ephedra, ginseng, mahuang, etc. also cause hypertension. Then some illicit drugs like amphetamines and cocaine, they are also notorious for causing hypertension. Then immunosuppressive agents, different cyclosporine and other things are also causing hypertension. Then psychiatric medicines, most of the psychiatric medications cause hypertension. You can see like all subpam medicines, tricyclic antidepressants, then SSR inhibitors and all, they are all causing hypertension in such patients. Then sex hormone therapies like estrogen and progesterone in OCPs and androgens are also notorious for causing hypertension. Then steroids, patients are on prednisone or methylprednisolone or Visolon tablet, that also can cause hypertension in normal patients. Then sympathomimetic drugs like decongestant or diet pills also can cause hypertension. So you have to take the drug history or uh, the history of the medicines which the patient is consuming. That is also contributing hypertension. So like if they are taking these medicines, yes, definitely they have a side effect of causing hypertension. That is like a iatrogenic or it is due to medicine. So either you have to inform them this is the reason for a hypertension, or you can modify the drugs or reduce the drugs, or you can replace it with the homeopathy medicines. Then only we can achieve normal blood pressure in such patients. Then we move to the best friend of hypertension is diabetes. I think Dr. Saji spent 2 days to discuss almost all the aspects of diabetes. And I just want to touch with the latest parameters and the development happening in the modern world regarding diabetes. So there is a debate going on who causes whom, or whether hypertension causes diabetes or diabetes causes hypertension. It's like a chicken egg relationship. Not only is hypertension more common in patients with the diabetes, but also diabetes is also more common in hypertensive than in general population. So we cannot say whether hypertension or diabetes cause the other vice versa. So there is a chicken egg relationship between hypertension and diabetes. So we have to learn this together. Then the study indicate that 2/3, that is around 67.5% of adult patients with type 2 diabetes have hypertension. So just imagine that means 70% of type 2 diabetes will have hypertension. So we cannot that is like we can say it's a latent sora or the sora as per Hanuman, no? Like so hypertension and diabetes go hands together. Like so it is very essential to check the BP of each and every diabetes patient comes to your office, because the convergence is so high. Coexistence of hypertension increases the frequency of macro and microvascular diabetic complications in these patients. So that is very essential. As we know, our aim of treatment is to reduce the morbidity and mortality, and that is like reduce the micro and macrovascular complications of diabetes and hypertension. Despite the critical role of hypertension in morbidity and mortality, only half of the patients have favorable arterial blood pressure levels. That means patients with diabetes are not able to achieve normal blood pressure levels. So that is also very, very important. That gradually, it's like a silent killer. If diabetes join together hypertension, the chances or the frequency of macro and microvascular complications are very high. They will end up in end-stage renal disease or chronic kidney disease, or there can be eye changes or retinopathy, or there can be cardiac issues, and then there can be neuropathy or nerves damage also can happen. So this is very, very important. So for each patient comes to you with hypertension, you should do the blood test for diabetes, and for each patient coming or present as hyperdiabetes, you should do the blood pressure also. Diabetes and hypertension were found to be associated with a significantly increased risk of cardiovascular disease, and a significant synergistic additive interaction of diabetes and hypertension on coronary heart disease was observed. That means the chances of getting cardiovascular disease is very sure if the patient is having hypertension along with diabetes. They did a study on this, and the participants who were old women, highly educated, unmarried, obese, had increased risk of diabetes and hypertension. That means they will end up with cardiovascular disease. That is why nowadays WHO also informed. Previously, it was believed that women are having the presence of estrogen make them cardioprotective. Now, the new study says that women are at more risk when they are nearing to menopause, and because of their lifestyle and dietary changes, they are more prone to develop cardiovascular disease than men. So that is also a warning sign or an alarming signal which we have to be taken care of it. And like your people, Meghalaya people are more exposed to tobacco chewing. That is also another predisposing factor for three of this one: diabetes, hypertension, and even in cardiovascular disease. So the insulin resistance and diabetes increase the prevalence of hypertension. So we say type 2 diabetes is mainly due to insulin resistance. So insulin resistance itself is a predisposing factor for hypertension. The underlying molecular and cellular mechanism in this one include inappropriate activation of the renin, angiotensin, aldosterone system and the sympathetic nervous system, enhanced renal and endothelial sodium channel activation, mitochondrial dysfunction, oxidative stress, inflammation, abnormal exonormal microRNAs, abnormal gut microbiota, as well as an increased renal SGLT2 activity. What is SGLT2? You heard about that? Any idea what is SGLT2? Any idea? What is the role of SGLT2 in diabetes? They are the prescription medicine now for to control type 2 diabetes. That is called sodium glucose cotransferase 2, and the inhibitor, because they are actively sodium glucose cotransporter, and there are SGLT1 and SGLT2, and they reabsorb glucose from the distal convoluted or DCT. So an inhibitor will leads to glycosuria, then the blood sugar will come down. So it's a prescription drug nowadays, SGLT2 inhibitors. So they play an important role in diabetes and hypertension also. That means that can together cause some kind of disturbance in the kidney, leading to renal problems. And like comparing to cardiovascular disease, renal disease are more difficult nowadays. Why? Because most of them are end up in chronic kidney disease. There they have to go for dialysis, and that leads to later they have to go for the transplant. Comparing to cardiovascular disease, like they can do an angiography, and angioplasty is very common nowadays, and the cost is also very less comparing to renal transplant. So we have to make sure that none of our patient, whether it is hypertensive or diabetic, will end in CKD, chronic kidney disease. That is the aim. That should be our aim of treatment also. So another thing, when diabetic nephropathy is the major driving factor for hypertension in type 1 diabetes, that means in type 1 diabetes patients, they are devoid of insulin, they are on insulin supplementation. So they will develop diabetic nephropathy. So if a patient develop diabetic nephropathy, you should check for the hypertension. It will come together. Diabetic nephropathy with hypertension is there in diabetes patients. But inappropriate activation of the renin, angiotensin, aldosterone, we have seen that RAS system and SNS system, mitochondrial dysfunction, oxidative stress, inflammation, abnormal release of extracellular vesicles and related microRNAs, as well as dysregulation of the gut microbiota and renal SGL2, sodium glucose cotransporter 2, are emerging as an underlying mechanism in the development of insulin resistant and type 2 diabetes induced hypertension. So diabetic nephropathy plays an important role in type 1 diabetes to develop hypertension. But in type 2 diabetes, all this together, RAS system, SNS, EV, microRNA, gut microbiota, renal HGF, all together play an important role to develop hypertension in type 2 diabetes patients. So initially, the patient may be diabetic only, but gradually they will develop hypertension also. So that's why I told you to frequently check the BP of a patient, diabetic patient who is under treatment also. Why it is important? HbA1c. You heard about A1c or glycated hemoglobin? I don't want to go in detail about this one. We know, like, because it's a nowadays WHO and American Diabetes Association approved A1c measurement for the diagnosis and follow-up of diabetes, especially type 2 diabetes. Why? Because it is more stable and it is not patient dependent. You know, like if you do fasting blood sugar, some patients will take their anti-diabetic medicine before going for the blood test, and it can fluctuate based on their emotions or their previous day night food, and nobody will go for 8 to 12 hours fasting. So the FBS is not that much reliable. And PPBS also, actually we defined PPBS based on taking 75 grams of anhydrous glucose. Then they have to go for the blood test. So what patients will do, they will take only one coffee or a little bit of sugar. So the PPBS value also will be altered. So we cannot rely completely on the patient. So from 2020, 2018, they came into the force that WHO and ADA, American Diabetes Association, approved A1c measurement as a gold standard in diabetes diagnosis and management. So the more important thing, yeah, what is your doubt, Mr. I can see that's KS. You can ask in the chat actually. You can search in American Diabetes Association. There, everything is mentioned there. Why it is significant? What are the pitfalls? In even in some cases of hemolytic anemia or some other hemoglobin related thing, the HbA1c value may vary. And second thing, we have to use a standardized machines to measure it. Otherwise, we'll get a false report. Some labs use Turvey method to determine A1c measurement. That will go wrong. But there are two machines, mainly the Biorad D10 is one of the machines used for A1c measurement. Other one is also one or two machines are approved in India also. So if you want to do A1c test, send to a lab where they are doing it on the machine, or you visit the lab and check with them. I personally did that. I have visited a DDRC lab and one lab HRD lab in my place. I have seen, and even I test by myself to verify that. Otherwise, what happens, we completely rely on the A1c value for the monitoring or the follow-up of the patient. So this is a very what you call trouble-free test actually, because patient cannot modify. I have seen patients will take metformin before they go for fasting blood sugar test, so they can cheat us. But A1c, it's like it's an average of 3 months. I don't want to go further details about that, because you should know, since you learned about A1 diabetes in detail for 2 days. Or you can brush up from the, you can go to in ADA site or PubMed also, you can see different publication on this one. And by 2018, if my memory is correct, from 2018 onwards, they made the gold standard in diabetes management is the measurement of A1c. Only problem, it should be done with a what you call, it's a standardized machine, not on they have given national glycopathic. There is an agency to what you call approve the machines, then it will be final one. So what is the significance of A1c? The slide shows that if you are able to reduce the A1c percentage, 1% reduction in A1c will lead to 21% reduction in diabetic related death. 14% of myocardial infarctions can be reduced, and microvascular complications can be reduced even 37%. And we can prevent the amputation or death even up to 43%. That means half of the amputation or death can be prevented if you are able to reduce the A1c level, A1c percentage at least by 1%. So that is the most important thing. That is the reason why the measurement of A1c is so important in diabetes management. So I underline that, but it should be done in a proper laboratory, you can physically verify whether they're doing it on a machine, then you can go for A1C test rather than depending on FBS or PPBS or random blood sugar. These are all obsolete now. Even in research studies, they can only accept A1C levels, but for the clinical use, we can go for FBS or PPBS, but this will be more what you call dependable one actually, because the total diagnosis and the management of diabetes nowadays depend on the A1C percentage. That is so significant in the management. So this is like just to show the A1C levels. You know, like the percentage between 5.7, less than 5.7 is considered normal. From 5.7 to 6.5 is the pre-diabetic stage, and above 6.5 is diabetes. So but the American Diabetes Association, they have designed, no, like in a established diabetes patient, even up to 7% is fine. That means the patients with the 7% of A1C, the chances of they going further into micro or macrovascular complications are very less. So there is no point of to reduce it further than 7 or 6.5. But if it is fine, if you want to declare that a patient is devoid of diabetes, the A1C level has to come less than 5.7%. Even if you say FBS is 100 less than 100, but you cannot say the patient is normal glycemic. If you want to declare the patient as normal glycemic, the A1C level has to come less than 5.7%. And this 5.7 to 6 point is very significant nowadays, because there are skyrocketing the number of pre-diabetic patients in our population, especially young people. So, and we can beautifully manage, or we can bring them to normal glycemia with our homeopathy medicines, and that will be completely reversible actually, because these are all based on the fact that the beta cells, the efficacy of the beta cells, if we intervene with our medicines the pre-diabetic stage, we can completely cure them. We can prevent them becoming over diabetes. So that is the most important significance of A1C measurements. So A1C level less than 6.5 or 7 in established diabetes patients considered to be safe and may be free from the possibility of micro and macrovascular complications of diabetes. So that is the significance of A1C levels. And there is another new standard of measurement came into force in 2022. That is called a glycemic target, or called AGP. That means ambulatory glucose profile. This is based on the continuous glucose monitoring. That's called CGM. And that is especially on a machine dependent one. And this is more indicated for patients with insulin dependent, like type 1 diabetes or type 2 diabetes patients who later in their later life rely on insulin, especially because, you know, like those who are on insulin, the chances of become hypoglycemia or the blood sugar go very high is there actually. So they have designed another parameter called time in range, GIM, time in range. Here what happens, the patient, there is a target fixed from 70 to 180 milligram per deciliter of blood glucose, and every 15 minutes they will take the measurement, and it is done for 14 days. And the report will come like this one. You can read that AGP, ambulatory glucose profile, continuous glucose monitoring, test and patient date of birth, then 14 days, August 4, 8 and 21. Time in CGM active is 100%. Then you can see average glucose 175, glucose management indicator GMA 7.5. The GMA has to come down less than 7%, and average glucose should be less than 150. The average means 14 days average. This glucose variability has to be less than or equal to 36%. In this patient, this is more than 45%. On the left hand, you can see an indicator. The blood sugar less than 54 is very low, 70 low. Then 70 to 180 is the target. Above 180 to 250 is high. Above 250 is very high. So the patients who are on dependent on insulin, they may even go to blood sugar less than 54, or they can even go up to very high of 250. So they will keep on fluctuating. So in order to monitor that, they designed a new way of diagnosing this one, that is called time in range. And you can see the patient blood sugar has to be in between 70 to 180 during the whole 14 days. So on the right side, you can see very high and high. You can see that is 44%. The goal is less than 25%. and the target is for this patient achieve the target is 46%, but the goal is to achieve a target of more than 70%. That means again the down you can see ambulatory glucose profile. It is that green indicator, you can see a line passing through that. So the target range 70 to 180. If the patient achieves more than 70% in this range, that means from 70 to 180, that means the time in range is good. That means the patient is having a perfect control over diabetes, and this is very significant in the management of type 1 diabetes and the patients who are on insulin for type 2 diabetes, or you can use it for the type 2 diabetes patients without insulin also. If the blood sugar is fluctuating very from very high to very low. So this is the latest diagnostic tool for diabetes. A1C is there, and apart from A1C, this is time in range. This is a little bit of complicated because it is machine dependent. Actually, you have to have a wearable machine where every 15 minutes the machine will do the blood test, and then it will record it and it will do an assessment after 14 days. The patient has to wear this wearable, like it can be like a sub-epidermal implant. It can be implanted and it will come connected to a portable machine there, and then the reading will be taken continuously, and they will do the assessment at the end of 14 days. Then they can see whether the patient is in the range, because in type 1 diabetes mellitus without insulin and type 2 diabetes mellitus patients with insulin or without insulin also, the chances of going into micro and vascular complications are very high, because A1C we are getting an average measurement 3 months, but this is like every day, every 15 minutes they are taking the blood sugar level, so they can see how long the patient is in the normal range of glucose. So time in range is another tool to determine whether the patient is under control with the dose of insulin and other things. So this also keep in your mind, A1C and time in range. Okay, then this is published by the glycemic target. How to do that? They came up with this one, like approach to individualization of glycemic targets. See, we cannot be so stringent in A1C measurement. You can see patient disease features more stringent, A1C 7%, whether it is to be strictly followed or less stringent. That depends on the patient parameters. Here you can see risk potentially associated with hypoglycemia and other drug adverse effects. In such patients, you can, if it is low, you can become more stringent. If it is high, you can become less stringent. That means even if HbA1c is not achieved 7%, you can leave that. Then disease duration. In a newly diagnosed diabetic patient, you can be more stringent, tell them to keep A1C less than 7. But if it's a long-standing diabetes, we can be a little bit lenient, then let them be around 7 to 8%. There won't be any, that strictness is not necessary or mandated in that case. Then life expectancy. If the life expectancy is more, that means around 40 or 45 years of old person is getting into diabetes, then you can be more stringent. But if it's a 70 or 80-year-old patient, no need to be very stringent to maintain A1C at 7%. Then there are important comorbidities. If there is no comorbidities, you have to be very stringent to reduce the A1C less than 7. But if fewer mild comorbidities there, then they have to be maintained at 7. If severe comorbidities, then there is no point of only reducing A1C to 7%. So you can be a little bit less stringent in that. Then established vascular complications are present. If it is absent, you can be more stringent. If fewer mild vascular complications are there, then you have to be ask the patient to become maintain at 7%. If it is severe established vascular complications are there, they are irreversible, and there is no point of being very stringent in that. Then patient preference. If you know some patients are highly motivated, excellent self-care capabilities. If you say don't take food in the night, they will blindly follow that. In such patients, you can be more stringent, but preference for less burdensome therapy. Some patients will say, I don't want to take too much of medicines. I don't want to take your drops or tablets or pills. I don't want to do much exercise. There is no point of you to become very stringent to maintain the A1C levels. Then resource and support system. if the resource and support system are not readily available. As I told you, like if you don't have any machines available for doing A1C and other thing, or the availability is comparatively less, then you should not be more stringent in maintaining. That means a patient from your village has to go to your capital city, which is Shillong, no, your capital, Meghalaya. So every 3 months, it's not possible for them to go and do that. If it is available near place, it's well and good. If the resources are limited, then there is no point of being very stringent in maintaining the A1C level 7%. These are all practical guidelines issued by American Diabetes Association in January 2022. So this is very significant because for managing hypertension, we need the support of management of diabetes. That's why I have, even though Dr. Sajid discussed about this one, I have take much time to again revise things and make you to understand the significance of managing diabetes in the management of hypertension. Hope you all understand well. No, like now you know, like we have to treat diabetes to control hypertension because they are the most important comorbidities end up in micro and macrovascular complications. Clear now? Any doubt? Or you're confused? Don't worry. This if A1C machines are available in your lab, you can go for that, or you can just continue with the FBS or PPBS. But nowadays the most gold in the standard is A1C and time in range. Time in range, you can see some well-off patients are wearing that for 14 days and they do assessment. Then based on that value, they will fix the dose of insulin, what time they have to take more in the night or daytime. So this will give a clear-cut picture of that. The further details you can visit the American Diabetes Association website, or you can Google it actually. But there is no point of simply Googling it, but you should understand that what is the significance and whether you are able to bring that into your clinical practice also. That is also important. So we will move to the specific part of our question, how to manage hypertension. What is the algorithm for that? So first we do check accuracy of blood pressure measurements, rule out diet and drug related causes. So if you get the blood, the blood pressure value more than 140 and 100 or 160/100. So first you have to check the accuracy of blood pressure measurements. We have discussed in detail about the BP measurements. Then rule out and drug related causes. As I have shown today's slides, if the patient is exposed to these kind of medicines, definitely yes, that is the cause for their hypertension. Or if their diet is like salt and what is it, high salt rich diet, then definitely that is the reason for that. So rule out that, then take the history, go for the physical examination, then do the lab testing. That means, as we have discussed, whether ECG is required or urine analysis or fasting blood glucose, hematocrit, electrolytes, creatinine, glomerular filtration, calcium and lipid profile. Then if you have any clinical clues like the causes for secondary hypertension like pheochromocytoma or renal artery stenosis, then you can proceed with that. But if there is no clue, but we suspect it is due to some kind of secondary hypertension, then if it's in a then the classification is different. If it is in a child, rapid onset or acceleration of hypertension or resistant hypertension, then you can follow this algorithm. If it's a child or adolescent, that means from birth to 18 years, the patient comes to you like we are not able to find a reason for that, then we can suspect any renal parenchymal disease or the coarctation of aorta. So you have to do urine analysis, urine culture, renal ultrasonography, and in some cases you have to go for with the echocardiography or MRA with the gadolinium, that is for the magnetic resonance angiography, and contrast media or CT angiography. When TSH also we will do whether to rule out any thyroid issue. So in children, this is the first protocol to be done, and followed be even up to ECG also we have to take in such patients. And in echocardiography, not ECG, echo also to be ruled out because of coarctation of aorta, you can pick in echo only. But if it's in a young adult between 19 to 39 years of age, first do the TSH. Then renal artery stenosis is the most important factor in them. So you can go for a, but in children or adolescent, no need for MRA, but in young adult only. In children or adolescent, you can go for echocardiography. Young adult, since we suspect thyroid or renal artery stenosis, you can do magnetic resonance image with the that's contrast with the angiography. Then contrast CT angiography you can do, or TSH measurement also you can do. Then if it's a middle-aged person, that is the significance of age. 40 to 64 years of age, it can be due to hyperaldosteronism or obstructive sleep apnea. What is our clinical tool to diagnose OSA? Any clue? We have discussed about it. We said we need polysomnography. Since if it is not available there, you can use this single small, what you call as a questionnaire, no, like a scale we have seen. What is that? Or you are all sleep apnea that time when we are discussing about that scale and all. Anybody, you can answer in the chat box. Let me see whether you are following the session or just log in and now you are taking your dinner there. Nobody remembers that? Yeah, Epworth sleep scale. That's a very what you call very easy one to follow in your clinic, because you will get many patients with snoring and all. So if a middle-aged person come, we have seen that hypertension in that patient, 40 to 64 years of age. Even we can think of OSA or Cushing syndrome or pheochromocytoma. In such cases, we can see renin and aldosterone levels, TSH, then polysomnography, that is sleep study, or you can use Epworth sleep scale for clinical. Then you can refer them for the polysomnography. Then since we diagnose suspect Cushing syndrome, 24 hours urine free cortisol you have to do. Then the 24 hours urine fraction metanephritis to rule out pheochromocytoma. Or you can refer if you find, that means you suspect some kind of pheochromocytoma or Cushing syndrome in this patient, you can refer the patient. That's what I want to tell you. Reference or taking a second opinion, you should make it mandatory. That is part of our prescription. So if you are doubtful, you can refer them. That's not a crime actually. That's the duty of a physician. But if it comes to an older adult, you know the reason for older adult, most of them will be because of renal artery stenosis or secondary atherosclerosis, or it can be due to CKD, chronic kidney disease, or ESRD, end stage renal disease. So a renal artery Doppler ultrasonography, just magnetic resonance imaging with the angiogram with the contrast, or CT angiography, then TSH, then routine urine analysis also you can do. So this is the algorithm to find out the secondary cause. It based on the age. 0 to 18 years end up in echo. Other one is like a renal parenchyma disease, or it can be due to coarctation of aorta. But when it's come to young adult, you can suspect renal artery stenosis secondary to fibromuscular dysplasia, not like an older age group. It is because of the stenosis. This can be due to fibromuscular dysplasia. That is the reason for the young adult secondary hypertension. Then we can do CT angiography or contrast MRI. Then middle-age group, we can suspect OSA, Cushing syndrome, pheochromocytoma. But when it's above 65 years of old, it can be renal artery stenosis or the other renal failure or chronic kidney disease. So this you can simply follow, and whenever you are in doubt, you can refer the patient to the concerned specialist, either to a general physician or to a nephrologist or to a cardiologist. You can do that also. So the American Diabetes Association in 2020 clinical practice guidelines suggest that non-pharmacological measures such as weight loss, regular physical activity, and limitation of fat and total energy intake should always be a part of any blood pressure lowering treatment, as it is the cornerstone of preventive therapy in patients with diabetes and hypertension. So before rush up to find out the symptom in this patient, or any patient comes to you with diabetes and hypertension, you should make sure that you should advise them on weight loss, regular physical activity, and limitation of fat and total energy intake. So you can give us an advice in along with your prescription. You can give a weight loss advice, physical activity. You can just write it up and give us like an advice. One is prescription, that is you are putting RX. The other you can put as ADV, that is advice, and you can attach that also. So this is the cornerstone of preventive therapy in patients with diabetes and hypertension in order to prevent micro and macrovascular complications. That means to prevent retinopathy, nephropathy, and all type of pathies. So make sure that you not only give him medicines, you should focus on this part also, because American Diabetes Association from their clinical experience suggests this one. Then there will be better compliance. Then there will be, you can reduce the A1C very fast, not even within 2 weeks or 3 weeks. Even though we are doing it in 3 months, I have seen many patients coming up with a drastic reduction in A1C with our medicine plus this non-pharmacological measures. Like I have seen a patient with 15.2% A1C. In 2 months, it came to 12, and in third month, it became around 8%. That means if you advise them to follow this non-pharmacological measures, then we can drastically reduce A1C. As you know, even 1% of this reduction in A1C, we can prevent half of the amputation or sudden death in such patients. So that is the significance of this lifestyle change advices. As you know, lifestyle modifications are essential for managing hypertension, and optimal treatment start with diet and activity. So no need to be hurried to go for a prescription. First, remove the causes. You know, like Hanuman suggested, what are the causes, removal causes or predisposing factors to be modified. Then dietary changes include salt reduction, moderation of alcohol consumption, and a diet high in vegetables and fruit that is low in added sugars and saturated fats. Example, they are telling dietary approach to stop hypertension. There is a diet called DASH diet. And your place, people are more meat eaters or more on veg side or mixed? How Mechalians dietary habits? I think they are using more salt and fat, no? Non-veg mixed. Okay, yeah. So this is very important. They ask them to moderate salt consumption, alcohol. What about alcohol? Yeah, it is there, no? Like so these are to be modified actually. Simply giving medicines will not help us to cure or manage lifestyle diseases. Then the other two is very important. Active recommendations. Active recommendations include aerobic and resistant exercise for at least 30 minutes or more at least 5 days per week. This is by Dutch. There is a RM protocol. That means Road to Modify Lifestyle Disease. They advise 30 minutes of aerobic or resistant exercise at least 5 days in a week. So that is they have studies and they have proven no need to go further than 30 minutes, but 5 days in a week, just do that. Definitely that will help you to control blood sugar or even hypertension, blood pressure without any medications also. And another important modifications include smoking cessation and stress reduction. So these are to be taken care of. Lifestyle changes including dietary changes, activity recommendations, and smoking cessation and stress reduction. That is very, very important, along with the pharmacological intervention. Is it clear for you? Or when a patient comes to you, you are just want to take the morbid phenomena, accident and symptoms, and then prescribe, or you will focus this area also. This is also very important actually, because this kind of psoriatic disease, we cannot cure it completely for sure, because the lifestyle is very important, but we can manage psora, no? Like the psora will be sleeping or it will not express its the full potential in such patients. So mind that this is also very, very important. But when a patient goes to a cardiologist or a diabetologist, will not advise much because they want to intervene with the pharmacological intervention. But we can, of course, because our medicines are like we are giving very small medicines, very small dose of the medicines. So definitely, even the this will supplement the action of our medicine also. Even though our medicines are capable of changing this one without any lifestyle modification or anything, but if we do this synergic effect, the effect will be more. Even we can say we can cure also. That's I told you, like if the blood sugar level, A1C level comes less than 5.7, you can say the patient is completely cured of diabetes. So then real life scenario or in your clinical presentation, how a hypertensive patient will come to you, or what are the different types of hypertension patients present in your office? One will be like patients with multiple diseases and their own medications. Such group of patients will be there for sure. Or some patients will be with multiple diseases and their own medication, but they are on resistant hypertension. What is resistant hypertension, by the way? Anybody to answer? What is resistant hypertension? No answer? Resistant to allopathic drugs, do not respond to anti-hypertension drugs, not responding much to. Exactly, Dr. Sujauddin answered correctly. Even with 3 antihypertensive medication, but the patient's BP blood pressure is not coming down. That is resistant hypertension. What is the axillary malignant hypertension? In malignant axillary hypertension, there will be organ damage also, but in RH or resistant hypertension, there won't be organ damage, but patient will not respond even after taking 3 antihypertensive medicines. One Lasix, one AC receptor inhibitor, or calcium channel, or beta or alpha blockers. So such patient presentation will be there. That is the reason they will tell you, I have been diabetic and hypertensive for the last many years. Till last few months, everything was under control. Now I am taking 3 anti-hypertensive medicines, but my BP is not coming down. Doctor, can you help me? So such patients also will come to your office. Then there will be patients recently diagnosed cases, but since the doctor suggests they will be on anti-hypertensive medicine, I will come to you and ask you whether, doctor, I heard that if I start anti-hypertensive medicines, I have to take it for lifelong, or the chances of getting other complications are there. How can you help me? Then, since yesterday I told you to start checking the BP of your each and every new patient comes to your office, you will also diagnose some hypertensive patients. We can say it's a virgin hypertensive patients, because you are only diagnosing till that day they did not know that they are hypertensive. So such patients also can present in your clinic if you start practicing checking blood pressure in each and every patient who comes to your office. Or some patients will come to you, they will say, doctor, my father or my brother or my relatives, they have non-communicable lifestyle disease like hypertension, diabetes, cholesterol. Now I feel I am not diabetic. What I can do to prevent that? So such patients also will come to your office. Or you will get some very advanced age patients. They may be bedridden, their relative will come and ask you, they are taking this much of medicines, their urine output is very less. Instead of taking this 10, 15, 12, 13 medicines a day, how can you suggest something? So we can also have some pain and palliative care in such patients also. Or patients on chronic kidney disease or end-stage renal disease or heart failure patients also can come to you, and they will ask you like whether you have any solution to reduce the number of medicines which they are taking. These are the cases come to your office, no? Anything to add on this slide, or you are not exposed to such cases? What is your clinical perception? You can just comment. These are no. Any other type of hypertension patients comes to your office? All except 6. Yeah, 6 is like no, like depends on how they are well versed with the efficacy of homeopathy, or if it's like it happens in Kerala. We are getting such cases because we are into pain and palliative. We are exposed to such cases, especially in medical colleges and even in our rural areas also. Now the government of Kerala, Department of Homeopathy is having such projects for them. So we are getting CKD patients, and for end-stage renal disease, they will come to us whether we can give some medicines for that. Okay, fine. It depends on our area of practice. the experience or the level of your practice also. Steroid overdose taken in COVID and hypertension. Yeah, steroid leading into hypertension, diabetes, or even steroid, even COVID-19 itself is a predisposing factor for development of hypertension and diabetes. That's why I told you, each and every patient comes to your office, you can simply check the blood pressure. Then you can put them as your fourth group, virgin hypertension, whom you are diagnosing, and tell them, then they will stick with you. If you diagnose a patient, for sure they will ready to follow your advices. Otherwise, it's not an easy thing to create a patient base in your place, in any place in the world. So if you diagnose this first, they will develop confidence in you. And these virgin hypertension patients are very easy to treat. As we know, in organ we have learned that the iatrogenic disease, that means a disease when a real or a psoric disease combined with the chemical medicines, it will form a complex disease where it is impossible to cure them. But if it's a virgin hypertension, then if you can manage them with your polycrest like sulfur, naxomica, lycopodium, that will be an easy prescription also. But if it comes with like in the group 2, like a patient with multiple diseases and on medications but on resistant hypertension, that's very difficult to treat, and we cannot cure them completely also. So this you can analyze your patients also, and you can work out. That depends on your, you can make your own protocol how to approach. Okay, recently diagnosed case but on antihypertensive medicines, whether you can stop it or you can follow another method to stop that, or start homeopathy medicines like that. So these are all clinically important actually. So now we are moving how to manage hypertension. So what is the most important thing in clinical medicine? The most important thing a doctor has to keep in his mind, that do no harm to the patient. If you think, okay, I will stop all the medicines and then start homeopathy as a single dose of medicine, if you are not sure that you are going to harm the patient, don't do that. So do no harm. Even if you are not giving any medicine, that's well and good, instead of harming the health of the patient. So that's the most important thing in clinical medicine. Do no harm. And second thing, you should get the consent of the patient. That is most important. The choice is the patient's consent actually. As except in some kind of epidemic disease or pandemic diseases, other thing, it is their decision. You can suggest them, you can give them the options, but the decision is from the patient side. You cannot force them. You can suggest them, okay, you can try homeopathy, but the decision has to come from the patient. And since in our Indian system, we don't have the written protocol or the written consent, but in all other places, they have to give the consent. Here we believe when the patient comes to your office, that they are giving the consent for the investigation or the physical examination or the starting the therapy. But you should ask the patient, this is the options, which option you want to take. Otherwise, when you suddenly stop this medicine, if anything goes wrong, they can sue you also, like you're harming the patient. Then the important thing is safety and efficacy of your treatment. It should be safe. If you don't know the efficacy of medicine, okay, somebody suggests you, okay, mix these 3 changes together and give, and you don't know the safety of this, don't do that. And efficacy, if you don't think your medicine is effective, then no need to go for any prescription. You should be like empathy towards the patient. So that is also important. Do no harm. Safety and efficacy is also important. Then must be aware of your strength and weakness in clinical medicine, your representation method or your material medical knowledge. See, that is also important actually. Since you are alone handling the cases, you have to be very careful, because we are playing with the life of the patient. That is most important. And another thing, as we know, in conventional medicine, an MBBS doctor cannot treat a patient with cancer. But in homeopathy, even if you are just passing out of the college, the next day a cancer patient and the stage 3 also can come to you and you can treat the patient. So we have to be more responsible, because we don't have the referral system. But in the allopathy, what you call, or the modern medicine, they have the proper protocol. An MBBS doctor cannot do surgery, or MBBS doctor cannot treat a cancer patient. An MBBS doctor cannot treat a myocardial infarction patient. We will get a my patient comes to you, you will say, okay, this is good, I will give my medicine, or arnica or something like that. So we have to be very careful, and you have to update your knowledge, update your clinical skills. So that is also important, because we are playing with the life of a patient. This slide, what you call, this is like nothing to harm any type of homeopathic doctors, but I'm telling you the reality. Never ever follow any school of homeopathy blindly. Rather, find out your own way of prescription, because some don't be carried away by the fantastic seminars, conferences, and case presentations. So this is nowadays happening in homeopathy fraternity. Some doctors will come, they will present some fantastic cases, they will say, they will share some kind of experience, then you will start practicing that in your clinic, which will be a miserable failure in your place. So I'm openly saying, don't blindly follow any school of homeopathy, because you have to, the reason is, I explained that itself. Another thing, master worship will spoil you, but mentors are helpful. So find some mentors rather than go behind the masters, because you are the master, you are driving the car. Every time you cannot ask somebody else help. Then homeopathy is a non-linear system of medicine. That is the other thing. As I told you, there is no protocol, there is no strict, what you call, procedures there. But you should be aware of the red flags, when and where to treat. That's most, as I told you, do no harm, and you should know the safety and efficacy of your treatment. So you should understand, you should take the stuff from others rather than blindly follow any school of homeopathy, because there nobody can cure complete cases in their practice actually. And the seminar people come, some they are not doing RCTs, like which is the scientifically accepted. We are all presenting case studies or some kind of clinical experiences. The experiences can vary from person to person. The nature of the patient comes to you. If it is more psychosomatic patient, even you don't need to give any medicine. But if it's a real organic cause, like in a complicated case comes to you, then you have to know the status of the patient. The knowledge of the patient. That means the knowledge of the disease is most important. So that is also very important. And make a referral and second opinion as part of your prescription. So when in doubt, refer the patient. When in doubt, go for a second opinion. If you have seen a young patient comes to you with the hypertension, and you don't know how the clue, it's not responding to the medicine, given a reference letter, what all findings you have seen in the patient, whether you check the BP, or you can write it and send the patient there. So when you start a practice, you should be knowing the one cardiologist in your place, one nephrologist in your place, one dermatologist in place, one gynecologist in your place, one pediatrician in your place. So you can visit them the moment you start a clinic. Tell them, doctor, I'm going to practice here. So if any patient comes to me, like whether I'm not able to do any needful things for him, or if I want to refer, then if you maintain a rapport, you can just send them the referral letter. So definitely the patient will have more confidence in you, and they will return back to you definitely. And most of the doctors from the allopathy school they know the limitation of their science, and we must know the limitation of our science also. If we do professionally, then definitely they will also help us. So this should be there in your place also. Otherwise, simply blaming the old school, like what all we are seeing the hangama happening in different parts of India, like we are like simply proclaim we cured even genetic disease, blah 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 and all. That will not work. People are more aware now. The exposure is more. They are even, I have seen patients coming with the what you call the implanted insulin implants there, or they are going for time in range investigations. So they are all advanced actually. So we cannot say simply go with the old kind of practice, but you can maintain a rapport with these doctors. So they will also refer the patients. If it is an eczema patients, a child with the eczema will come, definitely they will refer the patient to you. So also you can see, if you get a cardiac murmur, no need you to think about your medicines and spoil the child's future. Just refer them, go for an echocardiogram. If the cardio says it's okay, we can wait for a few months, then you can try homeopathy. So that kind of professional relationship will help you to gain more knowledge, more confidence, and make your prescription more precise, and you will get more patients also. So this is an request from my side, from my experience of practice in different parts of the world. So we have to be open to learn from them also, rather than going behind some kind of masters in our system. I'm not against any master or any school of homeopathy. All are doing wonders, but that has to be seen in your clinical practice. Unless and until you are able to do that, it's only in the textbook. So this is clinical medicine. We are, as I told you, we are dealing with human life. Yeah, thanks, Dr. Alfili. This is like everybody is saying. That's why I'm very openly saying. IHM is a platform where we are bringing good faculties. So we have to openly admit. You have to say. So this is like not. That's it. All the limitation is we are a non-linear system of medicine. So our prescription also vary from person to person, doctor to doctor, place to place also. We don't have any specific protocol. We don't have any what you call first line of drug, second line of drug, and our clinical what you call recommendations are limited. Actually, we don't have any much RCT to suggest such medicine. So till that we have to rely on our conscience, our common sense, and our logic. Now we are moving to the next part: how to prescribe in hypertension. As I told you, identify the modifiable cause. Yesterday we have seen elaborately of obstetric sleep apnea or what all the other factors associated with hypertension. Even immunity can play an important role. Today we have seen diabetes has to be treated to prevent hypertension. So that kind of things, then other salt intake or what are the causes for hypertension. We have to identify the modifiable causes, then advise lifestyle changes, then dietary modifications, limit or restrict probable predisposing factors. So we have to identify these are based on the patient's exposure. So these are all we know, like the slumbering flora will come up. So these are all Hanuman also described in detail. We have seen efforts in 5. I think Dr. Saji explained very in detail about that also. Then alternative habits and occupations. Instead of going for a tobacco chewing, if you can suggest something less harmful, or if the occupation is like a sedentary one, you can advise them to modify their office hours. Or nowadays in Western countries, they don't have any sitting arrangements. They are using some kind of treadmill like offices, or they will stand and speak to the customer like that. They are all modifying that. So we can also advise such to your patients also. So this is also part of prescription rather than simply giving our medicines, that we have to make sure. So this is from our complete diabetes repertory, online repertory. You can see the medicines given for the hypertension. You can use this as a pathological rubric. Then your prescription, you can be a classical prescriber, or that also depends on you. But what I suggest is like in some kind of advanced cases, LDHM, that means low dose homeopathic medicines are effective. And I'm just discussing some medicine. I don't want to give you any kind of what you call tips or anything. I have for the last 2 days, yesterday and today, we are discussing in detail how to approach each and individual cases, what all the parameters to be looked into in each and every case. So the prescription also like that. But I can suggest you some medicines where we don't have any other clause. There is a limitation of the what is it called, the physical physical quality of the patient's life is compromised. In such cases, we can think of our less harmful medicine. I don't want to say if you are using some tinges and other thing, we don't know how far it is causing the harm, but comparing to this triple or polytherapy, it will be harmless comparing to them. So some kind of medicines we know we can prescribe, and this Revolve is there for centuries with us. And I have read an article that Mahatma Gandhi was known to employ Revolve not for hypertension, but he used to take the route to make a tea that he consumed in the evening to help relax after busy overstimulated day. So maybe that is the reason Gandhiji didn't suffer from hypertension. I don't know exactly. Since he's using Revolve, maybe it's like a preventive for him also, but he was taking it not for prevention of hypertension, but for relaxation. It's like that is, the study shows that it acts on the cholinergic or the synapses. So that will cool down. It induces sleep also. So maybe if you are giving Revolve to the patient to get a good sleep, if good sleep itself is a cure for, it's a medicine for hypertension. Half of the lifestyle diseases like hypertension, diabetes, even autoimmune disorders are very high in a community where the sleep is not good. Even we have seen obstructive sleep apnea is a clearly shown factor for the development of hypertension. So Gandhiji, I think today is January 30th. We are celebrating his martyr day actually. So Gandhiji also has given some good comment on homeopathy too. So we are remembering our Rashtrapita. Am I correct? Nowadays, people, the new generation doesn't know who Gandhiji is. So he used to take Ravolfia, but in homeopathy prescription, we can use low dose Ravolfia, is suggested for hypertension. And the study shows that a systolic drop of 20 to 30 mm of mercury and a diastolic drop of 10 to 15 mm of mercury are normal in Ravolfia. This is a study by a doctor. He has observed that Ravolfia consistently works as well as other first-line antihypertensive drugs, and he has combined Ravolfia with other antihypertensive medicines. It combines well with diuretics, angiotensin converting and AC inhibitors, ARB blockers, etc. That means if we have seen resistant hypertension, there are three antihypertensive are not acting. In such cases, either you can ask the patient to stop AC inhibitors and start Ravolfia or your medicine. Like also, we can also modify their prescription with the consent of the treating physician. From you can discuss with the treating physician of the patient before doing any change in his prescription. That's what I told you. When you start the practicing, keep in touch with some doctors. They will definitely help you for that also. Then it has been reported some kind of nasal congestion and loose stools in the patients, those who are taking Ravolfia regularly. Nowadays, people are buying Ravolfia over the counter and taking as much as drops they want. So, and you know, like in the nasal congestion itself is an indication for hypertension. So if they are taking too much of Ravolfia, they will develop nasal congestion or even some kind of stomach upset and loose stools can be developed. Maybe some kind of gut microbiome is affected because of Ravolfia, we don't know, or there can be some kind of epinephrine issues and other thing also. So these are the two reported complications, but in your homeopathy dosages, and if you are not giving too much of Ravolfia, it's not that harmful. And we have seen the science, the modern science focused more on the reserpine of Ravolfia, but we can see n number of other alkaloids, indole like alkaloids present in Ravolfia, like ajmaladine. I don't want to read the names. These are even yohimbine is also there. So this is good for sleep inducing, and even it acts even this is prescribed for autism children, or it is even good for Parkinson disease also. So our drug proving also has to be we have to overhaul our drug proving methodology also. Simply looking into symptoms of the patient, rather than we can also go to the molecular biology, genetics, and other even epigenetics, molecular biology, cellular mechanisms. Then that will be more precise. Nowadays, we cannot. During Hanuman's time, people are more innocent. They will say the truth only. Nowadays, we have seen, as I told you, patients will take metformin before going for fasting blood sugar test. The blood sugar will be normal. So they want to make believe that their blood sugar is under control. So we cannot rely too much on the symptomatology, because that is also changing. The world is also changing. We have to understand that also. So Ravolfia is like a first line medicine in such cases. Like as I told you, like there can be much, or the already advanced cases, the much organic changes, and there is not any role of any kind of individualized medicine or holistic approach. In such cases, we can, or in initial as a replacement therapy also, we can think of Ravolfia. Allium sativum is a very good medicine for hypertension with dyslipidemia. That doesn't mean in all cases you are supposed to prescribe that. I'm just giving some kind of ideas, because it is having a vasodilatory properties. Arterial hypertension begins usually in 30 to 45 minutes after 20 to 40 drops of the tincture, but don't use over a longer period of time, because 20 to 40 drops, then they will start proving also. What is Allium sativum, by the way? Yeah, garlic. How about your culinaries contain the use of garlic there? Garlic, ginger, and all. You are using it regular in your food? Yeah, good. So that's like an anti-hypertensive, or we are taking this kind of spices to prevent hypertension, diabetes, and other stuff. What is your classic food in Meghalaya? Like any specific food, like we can call it in Kerala we say sambar, or in idli in Tamil Nadu and all. What is Meghalaya brand food? Any stuff, any food stuff like that? Yeah, you have many food, no? Like that's fine. Good, good. So hopefully one day we will come to Meghalaya to enjoy your local culinaries. Let's see. Okay, so this allium sativa contains allicin. The thing is, it acts on the transient reception potential A1 channel and leads to vasodilation. There is a channel. There are like transit TRP1, TRP7. So this act on the channels, like this is cellular channels actually. They can act on that, and that leads to vasodilation. Vasodilation leads to lowering of blood sugar. I mean blood pressure actually. And allium sativum, as I told you, it's a good medicine for the combination of hypertension with dyslipidemia. If we cannot find any specific medicine for this specific patient, then you can prescribe this as specific medicine for this combination of disease rather than not on a patient actually. In the sense, if you can find a similar one, that is well and good. Otherwise, in advanced case of hypertension, old age patient, dyslipidemia, not able to achieve the target, then you can think of allium sativum. Then veratrum album is helpful in reducing both systolic and diastolic blood pressure. It's an emergency, you can prescribe that also. Then paracetamol, as we have seen, we have discussed yesterday, like in old age, especially because of the arteriosclerosis or the vascular stiffness, there will be high systolic blood pressure with the normal diastolic blood pressure. But fortunately, unfortunately, the effect of paracetamol is not that much promising, because as we know, there is a limitation for this stiffness. That means if the vascular changes already happen, it's very limited actually. Don't think that you can give to all people above the age of 80 paracetamol and you can bring down the blood pressure. It will not happen. In clinical practice, is very difficult actually. Management of hypertension in super senior citizens is very, very difficult. They will be remaining in resistant hypertension for sugar. It's not an easy thing. It's like from the clinical point of view, I'm telling you, but initially they may respond. But if it's a younger age group, like less than 50, paracetamol will act nicely. In such case, if high systolic pressure, normal diastolic, that means there is no much damage on the heart, and the arterial stiffness is just about to start. In such cases, you can have a very good improvement in hypertension. But very old persons, it's very difficult actually. Then Viscum album, it is with the renal involvement actually, like a hypertensive albuminuria. But I have seen in some OSA patients, after that means it is written in boring, no, like stertorous breathing. You can compare that with obstructive sleep apnea. So if you are not getting any clue from the patient, hypertension with OSA, you can try Viscum album. In our homeopathy literature, they say Gubsain is the active principle. It is said to lower arterial tension, but the clinical evidence in support this is unconvincing. That means there is no statistical significance in that. The berries are purgative and emetic and are said to have emmenagogue and ecbolic properties when given in large doses. Its principal action is to depress the nervous system, especially in the medulla. But in meteoritic, we say they don't have any action on the central medulla portion actually, but it's action on that. That's why it's effective in obstructive sleep apnea also. I'm not sure, but we can just correlate with that. But this is called, the common name is mistletoe actually. The mistletoe extract induces apoptosis and cytotoxicity in cancer. So they are prescribing medicine for cancer actually. It also stimulates immunocompetent cells to promote immunomodulation, as mistletoe lectin is a beta galactoside specific lectin. This we can think of in diabetes, hypertension also, because I have told you immunity plays an important role. What are the interleukins we discussed yesterday? More specific in hypertension. Interleukin 1 or interleukin 7? Anybody? So we can link with Viscum album, its immunomodulation property. Yes, very good. Hariga and Dr. JC, Dr. Hariga and Dr. JC, yeah. Interleukin 23, interleukin 17, yeah. So we can roughly link that, or if you can do a study on this one, an RCT or any other study on efficacy of Viscum album on modulating the response of interleukin 23 or 17, or interleukin, the prevent the upregulation of interleukin 17 or 23 with the Viscum album. So like that, that can be a reason for this efficacy in hypertension. I'm not sure. I'm just suggesting you based on the these kind of studies. The most important pharmacological components of mistol extract are, we have said is gupsin, but it is viscotoxins and lectins. And they exhibit anti-tumor and immunomodulatory effects. This immunomodulatory effect can be a reason for the hypertensive, anti-hypertensive property of Viscum album. I'm not sure. I'm telling you. I'm just suggesting you. You can also do some kind of research on that one. Then we can say specifically, okay, hypertension with OSA and hypertensive album. That means end-stage renal disease with obstructive sleep apnea and hypertension. They can think of Viscum album if it's proven in that way. Then glonoine, we have seen glonoine for what do you call sunstroke and all, often used to reduce arterial hypertension, chronic interstitial nephritis. That means in end-stage renal disease or chronic kidney patients, initially it will respond. As I told you, chronic kidney disease and end-stage renal disease, it is very, very difficult to bring down the BP. If you give Revolve, even if you give constant medicine also, it's very difficult actually. Initially there will be response, initial stages of treatment, but if you get a patient without any much medications, it will be more easy. So we can consider glonoine in hypertension with the CKD or any kind of renal involvement. This is a suggestion, not a completely proven or not much data on that. Then we have seen some adrenaline or what is epinephrine in that repertoire actually. They act on the via sympathetic nervous system. We have seen RAS system, SNS. They are all playing an important role in hypertension actually. Then Grindila, this is a very good medicine actually. You can see hypertension, diabetes, COPD, APD, and OSA. We are prescribing Grindila for respiratory difficulty in breathing. But this is a good medicine for hypertension, diabetes, COPD, APD, and OSA. So, an old person with this kind of stuff, if you are not getting any other clue, you can try this Grindila for such patients also. Here also OSA is there actually. Then hypertension and diabetes, a combination, as we told, like if you are able to give this medicine, if you can bring down at least 1% of A1C or hypertension to 140/90, or we can improve the sleep apnea or gastric problems, then that's well and good. Then gelsemia also in presentation with vertigo, then hypertension, some kind of anxiety and fear, and it in early Parkinsonism, gelsemia is clearly indicated actually. We can I don't know how far we can prevent that, but initially yes, we can at least prevent the further progress of Parkinsonism, especially in hypertensive patients. We have seen hypertension is associated with the Alzheimer's disease. There is a link with the Parkinsonism also, but I didn't see much literature. I didn't go further on that. You can refer that whether any connection between hypertension and Parkinsonism. But I have seen few cases responded well with for the hypertension. Initially, that the Parkinson symptoms are much reduced. See, we cannot say it's completely cured, or we don't know how far we can prevent it, but we can suggest gelsemia. In such cases, there will be some kind of anxiety and fear. Then the patient will present with some kind of vertigo, BP is high. Then initial stage of Parkinsonism, we can think of gelsemia. Then tabacum. Actually, I told you I will not give you any tips for that one, but just giving you some suggestions. Don't think this will be like a proven, but some kind of clinical suggestion. If you are getting such advanced cases, tabacum is like hypertension, and they will develop retinopathy because tobacco exposure that can cause what you call the proliferation of retinal vessels. And then renal colic. Then if there is a history of coronary artery disease or chronic smokers, you can think of giving tabacum in resistant hypertension to reduce the BP. So you do one thing, you should document these things, and if you get any results in such cases, we will have another follow-up class after 6 months. Am I? We can do that, no, Dr. Elfil? Whether these kind of classes will really help you want to know that. Is it? So then only will, as I told you, we can be kind of linked together. Like you can also try some of this kind of medicines in your clinical practice. Then we will all sit together, because in homeopathy the problem is that we have only regional things, not an international. We don't have an international society for homeopathy to do like that. So just keep in your mind, record everything, because the days for data, everything based on data. Unfortunately, we don't have much data on anything. We are following hearsay, or we will say the master said like that, or we will say Hanuman said like that, or we say this scholar of homeopathy said like that. But then the new world will not believe in that kind of. They need to have data. If you have data on hypertension with retinopathy, renal colic, history of chronic heart disease, and smokers, they respond very well with the tobacco. If you have 100 cases, then that's a thing. Then we can do further study on that. Then that will become a documented one, and that is foolproof also. So we will make in that way. That is the real science. Then only homeopathy will become scientific. Otherwise, we can say proudly homeopathy is scientific homeopathy, but the others won't believe. Instead, if the scientific community has to accept it as, we have to be more on scientific, we have to follow the scientific protocol. Evidence-based medicine is a little bit different than this RCT and other thing. Evidence-based medicine is also fine actually, but their parameters also is a little bit different. Now the stages for meta-analysis rather than RCTs, because the problem is that we are, just imagine how many diabetic hypertensive patients we are getting, but we are not spending any time to record this thing and then follow up that also. That's our problem actually, because we don't have much research. We are all clinicians. We are all just, even I also didn't prepare the much slides for my clinical cases, because it happens with everybody. I'm not blaming anybody, but the new generation doctors can think of doing such things. Otherwise, homeopathy is fine, but it will become obsolete. You know that, because it's like, there were typing institutes, like we will learn typing, and now it's gone. Now even camera is gone. Everything is on your mobile phone. So the technologies keep on changing. So we have to update ourselves. Otherwise, we are all become, the things will be fine, but people won't use it. They won't come to us. So that is also very important actually. Then another medicine, Strophanthus, high systolic blood pressure, and that in especially chronic smokers and chronic alcoholism, they will develop anemia. There can be chance of goiter. This is given in the keynote. I think it's in Boric also. Either hyper or hypothyroidism. So hypothyroidism is present with hypertension in many cases. Hypothyroidism with hypertension. So you can think of Strophanthus or calcarea iodide, or even there are other medicines also. So that is some clinical clues we are getting. The combination of chronic diseases. So Strophanthus is also another medicine. Then these are some cases. I don't want to go further details on that one, because it's some cases I did the representation. I was able to bring down the BP, blood sugar under control. Then another severe asthenospermia case, the patient hypertensive. I use other rubrics, then prescribed phosphorus, and fortunately they are happy with one child now. Then premature gray hair with the Watson hypertension. I have given, I think, Sepia was given based on my what you call. I am not completely reporter dependent person. I am using my logic and common sense also. I have given this medicine. The water has gone, but the premature gray is still persisting. BP all under control. BP for sure not an issue, but premature graying, I don't know how far we can help that. In some cases we have seen result, but some will prescribe lycopodium, some will prescribe balitacar, but there are cases, but it's like the number of cases are very less. Then bruxism, grinding of teeth in an adult, hypertension, hypochondriasis. I prescribe lycopodium, improved very well. BP under control. I told you, like, with our medicines, they are not exposed to much antihypertensive. It's very easy for us to handle that. But don't think in all cases we can do. But if you advise some kind of lifestyle modification, and especially anemia is also an important factor. Actually, you have to check HB also. Some cases the hypertension is due to anemia. Anemia can cause hypertension, hair loss, and other features also. So keep in mind that also. Then another surveillance is nose, what on nose and hypertension responded very well with the caustic. Then that means we can prescribe, we can approach the case in our classical or what you call the individualization method or proposition method. Then if there is no other clues also, you can go with this kind of suggested medicine for your management. This is the most important thing you are going to face in your clinical practice, how to wean a patient from triple or poly anti-hypertensive therapy. The patient will come to you, as I told, they'll be resistant hypertension. They are taking T3 or 2 or more than 3 anti-hypertensive medicines and diabetes medicines, and they want to at least reduce the number of medicines. How can you help? Here I can suggest you a step-down approach. First of all, assess the case in detail. See what are the complications, near future complications we can expect from that patient. So you can think of what anti-hypertensive you can reduce first, whether elastics can be withdrawn or an ACT receptors can be withdrawn or a cancer channel blocker can be withdrawn based on the symptoms and the comorbidities present in the patient. Along with that, you can fix a transition period of 3 months. We will start with the homeopathy medicine without reducing dose of any anti-hypertensive medicine. Start with the homeopathy medicine, observe the blood pressure, then step down the medicines. Or OHM protocol means oral homeopathy medicine. You can use either low dose homeopathy medicines or individualized medicine you can prescribe, and follow the proper follow-up criteria also. So as a step down approach through the transition period, go to the homeopathic prescription, then follow up properly, then you can also try that. Our aim is to prevent further organ damage or limit the complications. In such cases, we can do this. This is what we are going to face in our clinical practice. Or if you start checking the BP regular, you will get unknown patients are unaware of their hypertension. There you can no need to go for step down or transition. You can start with your homeopathic medicines. Either first line of treatment, you can start with the individualization, like and then lifestyle and dietary modifications is very important in such cases. LDHM, see, that depends, like either you can give tincture, but not to give 10, 20, 30 drops. You can give 1 or 2 or 3 drops also, 5 drops also, or 3x you can give, 6s you can give, 12c you can give, even 30 also you can try. It depends on the case. As we know, the preference selection is dependent on many other factors. LDHM is not a medicine, it is low dose homeopathy medicine, that's it. So our aim is to prevent further organ damage or limit the complication, at least reduce the combination of medicines, like 3 or 4 medicines. Nowadays, for diabetes, they have started the SGLT inhibitors. So they will definitely have an action on the distal convoluted tubule. Definitely over a period of usage, they will develop chronic kidney disease also. So that also we can, we can replace, because since homeopathy is it's not a traditional, we are a camp practitioners, complementary and alternative. So we can complement or we can alternate with our medicines. So what is your target? We have to follow the parameters set by the scientists or the modern medicine doctors. They are also following a target. We can also, if you are able to follow the target with your medicines, that's well and good. Nobody will question you. So I'm just again highlighting the 1% reduction A1C, because that is the most important thing. If you are able to reduce the A1C 1% at least, you are reducing diabetes rate at 21%, 14% of myocardial infections can be prevented, 37% of microvascular complications can be prevented, even half of the death or amputations can be prevented by reducing 1% A1C. And I have shown you the financial burden, like it's around in America, in United States, every year they are spending more than $3 trillion, 3 trillion Indian rupees, equal to that amount they are spending. So if you are able to reduce that, that's good for the community, for the nations. No? So that's very good. So what are the targets? As we have seen in BP, 140/90, if it's diabetes, if it's associated with diabetes and chronic kidney disease, 130/80. If you are able to bring down BP to 140/90 with your medicines, then nothing to worry. You can proudly say the BP is under control as per your target. So you can tell the patient, now you are safe, fine with our medicine, no need to take any other medicines. Then A1C, as we have seen, if you want to bring it normal, That means actually it is 5.7%, but American Diabetes Association, once the diabetes is established, it's very difficult to bring it less than 6.5%. It's because the beta cells are damaged. So it can be up to 6.5 to normalize it, or even 7% is okay, fine actually. In an established diabetic patient, if you are able to bring down A1C to 7%, you can follow that regimen. That's it, no need for any anti-diabetic, or even if you are able to achieve 7% with your medicines, you can stop all the other medications for the patient, and you can say that you reach the target. Then if you are based on fasting blood sugar, 140, less than 140 with the diabetic patients, PPBS less than 180 with diabetes. But as I told you, FBS and PPBS depends on many factors, depends on the reagent of the pharmacy, depends on the time of the test, depends on the what food the patient is taking. So it is totally variable, but A1C is more or less fixed. Only thing, it should be done in a properly calibrated approved machine. That's it. So this for blood pressure and hypertension, these are the target we have to achieve. And if you are able to reduce every 10 nm of reduction in blood pressure, in systolic blood pressure, lead to a significant 13% of reduction in all-cause mortality. I told you we can prevent 50% of amputation diabetes or death due to diabetes by reducing 1% of A1C. If you are able to reduce 10 mm of systolic blood pressure, you are reducing 13% of all-cause mortality. So it's well and good. This is to be our target to achieve. Then as far chronic disease leading to renal failure, end-stage renal disease or chronic kidney disease, there the gold standard they fix, the nephrologist or the cardiologist fix this for the urine albumin creatinine ratio, or they simply called ACR. So you can also, and it's a very easy test also. They can just do, any lab can do this one. No need to take 24 hours urine or what you call other. There's not much sophistication actually, and this ratio will give a proper what you call status of the renal function of the patient. So there are three categories: normal, microalbuminuria, clinical albuminuria. Urine micro, not the urine microalbuminuria we are checking. We are checking the urine albumin creatinine ratio. That's called ACR. So you can see on this reference range category, spot collection ACR, they have given in 2 units, milligram per gram or milligram per millimole. Milligram per millimole is international standard, but in India we are using milligram per gram. That means the albumin creatinine ratio has to be like 30 milligram what you call albumin creatinine ratio is to be less than 30. That means for every gram of protein, 30 milligram of creatine can pass through the urine. That is normal. In microalbuminuria, that means the patient start developing little bit of complications if the ratio is 30 up to 300. But if it is more than 300, it is clinical albuminuria. So if you are treating a hypertensive patient, and if you are afraid of whether the patient will develop any kidney related issues, you can ask for a urine albumin creatinine ratio. If it is less than 30 milligram per gram, you can definitely say there is no harm for your kidneys. You can continue these medications. So in once in every 6 months, if there is another thing, you can repeat that, and you can, then you are justified. Not even any cardiologist or any nephrologist can question you. If you are able to keep this UACR at less than 30. If it moves to 30 to 300, then you have to get a second opinion from the nephrologist how to handle that patient. So this is the target in hypertension or diabetes, the kidney function. Before it was like creatinine and then blood urea nitrogen and then microalbuminuria. Now they are focusing on urine albumin creatinine ratio because it's not a very costly test, and it is affordable, and it is easily available across the lab around the, especially in Indian subcontinent actually. So you can ask for this test also. If you diagnose a hypertensive patient, and since you are diagnosing it for the first time, you can ask for a renal function, not go for all the renal function tests. Just ask the patient do urine albumin creatinine ratio. Then to be more precise on CKD, that means if the patient is developing the chronic kidney disease, there's a classification based on the GFR. estimated glomerular filtration rate and albuminuria. So you can see from the green, yellow, then orange, and in red. In some patients chart, you can see G5A3. You can see on the right end, G5A3 means the patient is progressed to end stage renal disease. Only transplantation will help them, or they have to keep on doing dialysis at least 3 days in a week, alternately 3 days in a week. So the EGFR they are calculating, they can calculate, any lab can calculate EGFR, and then this albuminuria that we have seen from the ACR ratio. ACR is also classified in A1, A2, and A3. That you have this is given in milligram per mole. We have seen that milligram per mole or milligram per gram. If it is milligram per mole, 3 to 30 and above 30. If it's milligram per gram, 30 to 300, above 300. That's it. So they are classified into that category A1, A2, A3, and based on the GFR. If the normal GFR is to be above 90 ml per minute per 1.73 minutes, so that's a body size actually, body mass size actually, or the area of the body. So normally 1.73 or it can be up to 2 meters actually. So if the estimated GFR is more than 90 ml per minute per 1. That is normal actually, FG1. That's called grade 1 actually. If there is albuminuria in A1, that means less than 30, there is no CKD. You can say there is no CKD, the patient can continue like this one. Or there is a slight reduction in the glomerular filtration, that from 60 to 89. That means if the GFR coming down up to 60, and if there is no UACR, that is urine albumin creatinine ratio, is less than 30, that also you can say there is no CKD. But if the category changes is if the urine albumin creatinine ratio is more than 30, that means 30 to 300, then there started the kidney issues. Even if the GFR is 90, it falls into the category A2, then definitely the patient is progressing into CKD. So even if GFR is normal, but if urine ACR, that means albumin creatinine ratio, is more than 30, then the patient is developing, or this already developed CKD, chronic kidney disease. So GFR is less than 90, albumin creatinine ratio less than 30, no CKD. Even if GFR is reduced even up to 60, but if the urine albumin creatinine ratio is maintained less than 30, then there is no CKD. The other thing is there, if the GFR is less than 50 ml per minute, and even if what you call, there is no if there is, even if eGFR is less than 15, but urine albumin creatinine is maintained at 30 also, but that is also developed into CKD. So that is the combination. So GFR up to 60 with the UAG ACR less than 30 is safe. More than that, the patient is developing into renal problems. But this categorization will definitely help you to monitor the patient. If you are able to bring down from 300 to 30 milligram per gram UACR, that means albumin creatinine ratio, if you can improve GFR, then you are curing the case. But mind that it's not an easy thing, as we say in theory and textbooks. This is the real classification, and based on this one also, you can assess your patient. You can assess the progress of the patient. So this also important. Then even though we didn't discuss about dyslipidemia, as I told you, this trio, hypertension, diabetes, and dyslipidemia, leading to vast complications. So the cholesterol level also, like up to 240 is normal. You will not see any patient with it less than 200. If you are a rice eater, or if you are consuming, if you are eating, or your sedentary lifestyle, for sure it will be more than 200, or they have to take some kind of statin drugs. So the borderline up to 240 is normal. Not worry much on that. Triglyceride less than 150 is desirable. Up to 200 is borderline, but more than 200 it's risky. Actually, you have seen hypertriglyceridemia. Familiar hypertriglyceridemia is also there. The HDL nowadays people are walking less, so the it will be less than 35 to 45. To be on safer side, it has to be more than 60. But if it goes less than 35 in females, you can see it will be mostly less than 35. Blood cholesterol will be more than 240. Ask them to do cut down the use of rice actually. Then LDL also it has to be less than 160 or less than 150 or 160. Then the cholesterol HDL ratio, it has to be maintained. For that is not possible, because in such patients the total cholesterol will be high, then the HDL also be low, then naturally it will be more than 7, 10 we have seen. So that we have to specifically advise them to start exercise. HDL cholesterol will improve if you do active exercise. There are some food suggesting for that, but there is no much clinical evidence for that. But yes, of course, that road to health, that advice like 30 minutes aerobic or resistant exercise, 30 minutes a day for 5 days a week will definitely improve HDL level. Actually, some suggest some kind of soya bean, sunflower seeds and other things for improving that. And some medications are there in the market also. But nowadays some doctors focus on the VLDL, it has to be less than 30. But VLDL also, these values are synthesized, but mainly focus on cholesterol, triglyceride and HDL value, because HDL is an indicator for the our physical activity. So that is one way it is important. As far as fasting blood pressure and PPBS, fasting plasma glucose and PPBS are concerned, fasting plasma glucose will definitely give a clue to the status of the liver actually. So if FBS is or the fasting plasma glucose in the pre-diabetic stage, the chances of grade 1 fatty liver is there. So that is important. But in postprandial blood sugar, that shows the insulin activity or your physical exercise. You can improve PPBS level by doing regular physical activity. It will reduce the PPBS. But fasting plasma glucose depends on your liver function and the insulin also. In that, you have to be more careful. If FP, even though pre-diabetic, we can say impaired fasting glucose or IFG or impaired glucose tolerance. Impaired glucose tolerance means the 2-hour plasma glucose will be more than 200. Impaired fasting glucose, the blood sugar will be more than 124. It will be between 100 and 125 in PPBS, or 2-hour plasma glucose. In impaired glucose tolerance, it will be 140 to 200. But more sensitive will be impaired fasting glucose measured by the fasting plasma glucose, because it depends on the health of the liver actually. The other one, 2-hour plasma glucose, you can modify with the regular exercise also. So this is like these are the target you have to achieve in any kind of treatment, whether you are giving homeopathy medicines where they are giving antihypertensive or anti-diabetic medications, or they are giving some kind of Ayurveda medicines or some kind of naturopathic medicines, or they are on vegetarian diet or anything. These are the proven what you call target to be achieved. So mind that this is a deadly combination of diabetes, hypertension, dyslipidemia. If you are able to manage it properly, you can bring Imbha to their life. The pronunciation is like that, no? Imbha, that means the wholesome life. So thank you, doctors. I think here we can end the 4-day session on how to bring a wholesome life for Imbha. We have gone such a vast detail about hypertension and diabetes and how to prevent that, how to prescribe, how to manage in your clinical settings. I express my great gratitude to the organizers of IHMA Meghalaya chapter for inviting for this last 2 days to discuss these things with you and learn from your experience and share your clinical knowledge. Now I think we can just go for some quick doubt clearing session, or if you want to add something, you can also add from your clinical experience. You can share your experience, but I want to make sure that at least you should do 2 things in your clinic, 3 things in your clinic. One, you have to do blood pressure measurement each and every patient comes to your clinic. Second thing, keep one weighing machine and height measuring and do the BMI calculation. Third thing, Epworth sleep scale. You can print it and keep it. When any patient comes with sleep apnea, you can do that scaling. So this will definitely enhance your clinical skill and your confidence will be high. We may do a review session after 6 months, how our doctors from Meghalaya will do that. So that will make us more confidence. So collect the data. So the data will speak for us. That's simply saying similima is the best mode of treatment. We can clinically prove that also. So if you want to add anything, you can open up and discuss, or if you have any questions, you can ask in the chat session.
Anyone have any doubts, please? You can unmute yourself and ask, or you can put in the chat box. Yes. No doubts? Anyone has any question? Okay. Looks like everyone is clear with what sir has explained to us. Okay, one question we have.
Yeah, Dr.
Yes,
Kanchan.
yes.
6C used mostly in which case of hypertension? We cannot, as I told you, we don't have any specific protocol to which type of hypertension cases we can see 6C. It depends on purely on the clinical experience. In which case of hypertension means, what do you mean by that? What type of hypertension? Whether it is a resistant hypertension, or it's an accelerated hypertension, or it's hypertension with diabetes. That's it. As we know, like the protein selection is a skill depend on the physician who is being considered by the patient. So we can just say in general, yeah, it's in general. As I told you, like instead of giving tinges, you can give 6C or 3X also. There is no much difference in that. But if you are giving 6C or 3X, you are reducing the chances of any kind of side effect seen in using the mother pictures. And there is no specific studies to, okay, I can say, okay, Rustux, I mean, so for example, we are giving Strophanthus 6C is better in hypertension with cardiac disease or something. We don't have any data to say that. We have only some kind of clinical thing only that varies from person to person. So that's a good way how to improve gut bacteria or microbiome. So we have seen fasting is one of the best thing, and don't eat too much of what you call combination of food, like one meat, one fish, one poultry together like that. Then there are other lactobacillus are there. There are many ways to improve that, but fasting is one of the proven way to improve the health of gut microbiome. So that is why fasting is a very good measure to control lifestyle disease also. Is 120/80 mm measurement is obsolete because that is what we are taught? No, that is obsolete nowadays. As per, you can go and search in American family physicians website, because 120/80 in a chronic what you call patient with diabetes, hypertension, and CKD patient, it's very impossible to achieve that target. That's why that is being set into 140/90. In 2014-15, there is a big fight happening around the world with among the cardiologists whether to bring down the BP from 140/90 to 120/80. What is the benefit? So they discussed in detail. They waited for many kind of RCTs and they did many meta-analysis. So they have seen that bringing 140/90 to 120/80, the patient has to take 3 or 4 antihypertensive medicines. Most of the patients are reluctant to do that, and there is no much change in mortality and morbidity in bringing down. I have seen the slide yesterday also. Even 130/80 also, there is no much improvement in the overall outcome in the patient. That is the reason. So now we can target 140/90, not an issue. If it is able to bring down 120/80, it's well and good. What about for the first time diagnosis, hypertension should be take? No. If it's, as I told you, if you want to diagnose the first line, you have to get 180/110. Otherwise, you can 140/90 is hypertensive, but that we don't know the reason for the patient to have that BP. So you have to check at least 1 to 4 times, at least every week, 4 times like that. You can do that. Otherwise, there should be some cardiological involvement, either some kind of what you call ectopic beats or rhythm change or some kind of cardiac issues there, then you can diagnose hypertension. Otherwise, seeing 140/90 in first incident, you cannot declare hypertension. You can say, you can just suggest the patient, now your BP seems to be 140/90, we will do, or you can repeat the same day or after 1 week, or like that, at least 3 to 4 measurements for sure you have to do. Other it can be due to some diet or drug. Running nose is commonly seen in hypertension patients is due to tablet chronic hypertension. Many patients we can see that. See, as I told you, hypertension we have seen it is associated with some kind of immunity problem. So we have seen interleukin 23 and 17 are upregulated in such patients. So they are more prone to allergy symptoms. So hypertension will be presenting as recurrent allergy also. That is why we have discussed in detail about immunity and hypertension. But nose block, sometimes they will say some kind of obstructive feeling in the nose that can be due to hypertension also, or allergic rhinitis is more in hypertensive patients because of the immunomodulatory mechanism playing behind that. You can go through the yesterday's presentation. We have include all the points there. So what about if right hand 130/80 and left hand 160/100? How do see that is we call subclavian artery stenosis. In such cases it can happen, otherwise it will not happen. Maybe 10 up to 10-15 mm of mercury changes can happen. Then if you are doubtful about that, you can you can go further investigation. If you are getting one right hand 130/80, left hand 160/100, that called subclavian artery stenosis only. If it is like that, you can send the patient for referral, because they have to go for the further investigations. Many high dose steroid used in COVID second wave injectables for cytokine storm. So LBH reversed now after 4 months by adonics and sulfur constitutional, but hypertension continues in 14 male patient overweight. I told you, like it's very difficult to bring down the BP of patients who are exposed to usage of steroid, because we know their immune modulation is already happened. That is like some kind of upregulation of some kind of interleukins will remain in the patient. So LVH is reversible actually. Once the cytokine storm is gone, that can be reversed. I don't know whether it is due to 4 months adonics or sulfur. If the medicine is effective, then the BP also has to come down. But it can happen even LVH reversal to a certain extent. It can happen after the the cytokine storm. They are giving this steroid to prevent that, but that make a dreadful combination also. But in such, we have seen the drugs causing hypertension. Steroid is notorious for that. Even after the withdrawal of steroid, maybe it will take 6 months to 1 year. You can try Tucrium in such cases, because Tucrium, Mariamera Tucrium is not only indicated for worm complaints, it can be given for just like Naxomica. You can think of Tucrium also. I have seen some results in Tucrium. Tucrium tincture or 3S you can try for such cases, because they can remove the effects of, because Tucrium also some kind of immunomodulatory action is there. Antidote by homeopathy to steroids to a certain extent. Yeah, that's the Tucrium, Naxomica, or a constitutional medicine also. But some advanced case, some damage happened in the vasculature, because the hypertension can be due to the capillary problems or the venous or arterial problems also. But in especially in SARS-CoV-2, what happens? The ACT receptors can be that will be upregulated. ACT receptor in the sense that that is upregulated even after the patient is cured of SARS-CoV-2 virus. That means get rid of the virus, but the changes happened in the vasculature may remain. But after 6 months or 1 year, it will come down. That is why there is a good scope for homeopaths to treat post-COVID complications. In such cases, we can see. But bringing down the blood pressure is not an easy thing. As I told you, we have discussed the different, the things play behind that: environmental, genetic, immunological. Too many factors are playing that. So you have to identify, or we don't know which part the patient is, the specific patient is sensitive, whether they have to modify the lifestyle or tobacco exposure or sleep apnea problems. There are n number of factors actually. So it's not an easy task to bring down that. That is why even after using 3 types of antihypertensive, 30% of patients remain in resistant hypertension level. If you ask a general physician, they will say hypertension management is very easy. But if you ask a cardiologist, he will say the most difficult disease to treat is hypertension. For him, for coronary disease or LVH or any even OCM also easy, but they will say hypertension is most difficult. That based on the cases which we are seeing. If there is, as I have shown in the last slide, like that EGFR and UACR slide, if the kidney damage started, because kidney contains, you imagine the glomerular in a kidney. So how much of filtration is happening to this minute capillaries? So any slight change is happening, because the kidney, there is not only the this function is an endocrine part also. We have seen renin is being produced from there, erythropoietin is produced from the kidney. So that also contributing to the development of hypertension. So once the renal issue started, it's very difficult to bring down the BP. So the treatment should be preventive. That's what I told you. We have to check the UACR, that means albumin creatinine ratio, and EGFR, and label the patient. If they are in no CKD, it's well and good. Once it started occurring, it's slowly progress. Even with any medications, it's very difficult to manage. So the prevention is better than treating such cases. That's why in detail I have shown everything about these combinations, and even because CKDs or end-stage renal disease are skyrocketing anywhere in the world, the notorious causes are hypertension and diabetes. So the aim of the treatment for hypertension diabetes is to prevent the dialysis and renal transplantation. So that is why where we have to contribute from our side also, get some data from that. So do these investigations and see your target, fix that. Then you can also proudly say we are also doing something grateful. As I told you, 1% of reduction in A1C can have a drastic change in the management of diabetes also. Any other doubts? I think this is more than enough. So for 2 days,
Yes.
brainstorming,
Yes, sir. That was a very informative session, especially like you have explained very elaborately right from the beginning on how to tackle the challenges, especially what we face in the management of hypertension, and also uh, explaining how to prevent with the non-pharmacological recommendations, the lifestyle modifications, and especially you have given us many tips and research related suggestions that we can contribute to our system, and also especially the clinical aspects on how to prevent these cardiovascular complications by um, uh, understanding all these causes. So without further ado, I would invite Dr. Morisa to please give a word of thanks.
Hello everyone. I am Dr. Morisa Clem. Am I audible to everyone?
Yeah.
Yes.
First of all, I would like to thank God for providing us this opportunity to be a part of IHMA so we can arrange the Imbha webinar and for all of us to be a part of it. On behalf of IHMA Meghalaya chapter of this barrier and all its members, we give a big thank you to the National Working Committee member who have given their precious time to encourage, guide, and help us from the first day that we planned this webinar. The gratitude goes to our IHMA National President, Dr. Arul Vanan, for inaugurating this program, our National Secretary General, Dr. Bashir, and Dr. Maya Rani, our National Secretary Administration, who were our advisor people who we call whenever we face any problem. We would also like to thank Dr. Suresh Babu, our National Secretary Finance, and Dr. Ramesh, National Secretary Registration, who help in maintaining our registration and membership fees. We also wholeheartedly thank Dr. Deepu, Coordinator Technical Affairs, IHMA Kerala, for helping us in managing with the webinar registration and for arranging this Zoom meet. We express our heartfelt gratitude to our faculties, Dr. Saji and Dr. Simpson Joseph for giving their valuable time to prepare, present, and even share their experience with us, which is really needed by us homeopaths, especially during these days where lifestyle disorders like diabetes and hypertension are prevalent. Thank you so much, sir, for everything. We also thank the organizer of Imbha, in spite of being doctors with responsibilities in different hospitals, CHC and PHC, still they are willing to sacrifice their free time in organizing this webinar. So it will be a smooth running webinar. Finally, I thank all the delegates from Meghalaya and all over India and even abroad for being a part of Imbha. Without you, this webinar would have been just a dream. We also apologize if there has been any fault or disagreement from our part. Till we meet again, thank you, one and all. Good night. Thank you, sir. Thank you, everyone.
Thank you. Thank you.